So my name is Marcus Ford. I'm attending in Memphis, Tennessee at the Campbell Clinic, and I have the task of talking about modern understanding of knee function, which is going to be a little bit tricky following Dr. Blaha. No pressure. I do have disclosures. The most relevant one is I am a drinker of the kinematic alignment Kool-Aid. I am a drinker of the belief that a medial stabilized knee is the most anatomic we can get. All right, so most knee implants today are designed based off of two theoretical knee models, which we've talked about just recently. And these were popular back in the 1970s. So both models were created based on lateral radiographs and only represent knee motion in the sagittal two-dimensional plane. In the lateral plane, they were unable to find a single axis of rotation for the knee and therefore developed this more complex multiple radii, or this more complex model where the center of rotation changed with degrees of flexion. This was called the instantaneous centers of the knee model. Interestingly enough, this led to the design of the multi-radius femurs, otherwise known as J-curve femurs. So these even knees today, the Persona, the Attune, the Journey, are all based off of this J-curve model. The other model which you've heard of is the 4-bar linkage model. That was developed because basically in the same two-dimensional lateral radiographic analysis, they noticed that the femur pulled back and rolled back off the tibia. And so the only way to model that was to assume that the AC and PCL were like these solid bars that helped push and pull the femur back as the knee went into flexion. And so they designed knee replacements originally to allow for this femoral rollback, right? So posterior stabilized knees, they had a cam post mechanism. And then for cruciate retaining knees, they had the cruciate ligament retention, which helped pull the femur back as the knee went into flexion. Where am I going? There we go. So then we go into in the early 90s, Ann Hollister was the first to really refute the instantaneous centers of rotation model. She used a mechanical axis finder and used these LED diodes on the tibia along with cameras to track the knee in motion. So she noted a single axis of rotation for the knee. It just happened not to be in the sagittal plane. On the left here, you can see the cameras in plane with the flexion extension axis, making it a perfect circle. And then to the right, you can see the cameras perpendicular to the axis, making a straight line. And so this proved that the knee did not actually have a J curvature with multiple radii, but instead it had a single radius of curvature. And then we get into MRI technology. So Freeman and Pinskarova were able to look at normal knee motion in multiple planes. They noted that the contact point between the medial tibia and the medial femur did actually not really move through knee flexion, while the lateral femoral condyle appeared to slide backwards on the lateral tibia as the knee went into flexion. And so the 4-bar linkage model was, with this whole idea of uniform rollback, was really disputed. And it turns out, in reality, the tibia rotates internally about the medial femoral condyle when the knee flexes. So the tibia can internally rotate as much as 20 degrees or 2 centimeters. And so it was this more modern understanding of knee anatomy and function and kinematics to where companies started to develop their medial pivot designs, which is what we're here talking about quite a bit today. And so a well-designed knee prosthesis has intended benefits. So if you go look back at Doug Dennis and Comistak's data, when they used video fluoroscopy, they found that the knee implants didn't do actually what they were designed to do early on. And so during gait and stance phase, here's a cruciate retaining implant where the femur actually paradoxically transfers or moves anteriorly based on the base plate. And then similarly, in a posterior stabilized design, the femur is moving anteriorly in stance phase and as the knee goes into flexion. So there's this paradoxical motion. We then move into Munat, where he did similar analyses on a medial pivot design. And the interesting thing is basically with the medial ball and socket design, the femur didn't have that anterior paradoxical translation, but instead the implant conferred sagittal stability throughout a gait and knee flexion, which was more representative of having an intact ACL and intact PCL. And so it's, this idea of spherical geometry that confers, that basically better replicates normal knee anatomy. And it's this whole idea that a ball and socket design or a more constrained medial side helps replicate more normal knee kinematics. And so we're having prevention with the more constrained medial side through the polyethylene. We're preventing the anterior paradoxical translation of the femur. And then the less constrained lateral side helps for more anatomic rotation, translation, and rollback as the knee goes into flexion, so more anatomic. All right, so we're going to take a step back now and go back to Hollister. So Hollister did show that the knee had a single radius of curvature, as we talked about, and clinicians were looking for a way to basically find the flexion-extension axis of the knee. And throughout much of the 1990s, it was just deemed that the transepicondylar axis best approximates the optimal flexion-extension axis of the knee. We then go into the early 2000s, and where Eckhoff found that if you model the knee in a three-dimensional space, you actually find that the flexion-extension axis can be described as a cylinder between the medial and lateral femoral condyles. His group found that the difference between the true cylindrical flexion-extension axis and the transepicondylar axis could be off by as much as 11 to 12 degrees. And so they concluded that the only way you find the true flexion-extension axis isn't really through the epicondylar axis, it isn't through a rod in the femoral canal, it's instead through the actual articular surface of the femoral condyles. In addition, if you go to data from University of Vermont, they looked at the patella and the patellofemoral joint looking for a flexion-extension axis. And so what they were able to find is that the patella, in fact, had a single arc, and that flexion-extension axis of the patella was actually parallel to the flexion-extension axis of the tibiofemoral joint. And then so finally, we go back to Freeman's work on rotational movements of the knee during flexion and extension. Again, he showed that the tibia internally and externally rotates about the axis that passes through the medial femoral condyle contact point, and that is deemed the internal-external rotation axis of the knee. And so if we go, we really have these three kinematic axes of the knee. We have the flexion-extension axis of the tibiofemoral joint, we have the flexion-extension axis of the patellofemoral joint, and then we have the internal-external rotation axis of the tibiofemoral joint. And all of these axes are parallel or perpendicular to the prearthritic joint line. And so this was really the birth or the beginning of kinematic alignment as what's described today. And so knowing this, back in the mid-2000s, Stephen Howell originally with Otis Med was trying to develop pre-made cutting blocks to where you could reestablish the prearthritic joint line, thus having implants that are collinear with the kinematic axes of the knee. And again, if we go back in trying to find the flexion-extension axis, we know it's not really the transepicondylar axis. You have to find it based off of the cartilage thickness on the femoral condyles. And so that's what developed into this whole idea of calipered kinematic alignment, to where really the only way to truly find that prearthritic joint line and that flexion-extension axis is through a caliper technique, through measuring of the cartilage and placement of the implants. And so I do have to say thank you to Microport for having me. In addition to Michael Hellman, who's a prior co-fellow of mine who gave a very similar talk, who had some helpful slides. So, thank you.